So now I want to talk a little bit about the implications of all of this. How does all of this translate into what you actually do in real life? So we work with companies building all sorts of cool stuff, but I'm going to highlight a few examples that really take advantage of trusted data, LifeGraphs, and these new network models. So I mentioned value-based care earlier. This is an area that really brings all of these concepts together. So both payers and providers are trying to figure out how to optimize these value-based care plans. And one of the biggest issues is lack of data. Providers want to understand more about a person so that they can choose treatments that will have the best outcome based on each person's unique needs. They're also trying to compensate providers based on a more nuanced definition of what quality actually looks like. So payers, on the other hand, are trying to understand how to optimize their coverage options based on this deeper view of what would work best for each individual person. They have lots of claims data, but they struggle to get a hold of clinical and demographic data that would help them do this kind of analysis. And people are often really hesitant to give their insurance company more information, and rightfully so. They're worried that it's going to be used against them. In both cases, there's an opportunity to use trusted data, LifeGraphs, and consent and governance to make value-based care and value-based contracting much better, both for people and for the industry. The second area I want to touch on is really an extension of how you use LifeGraph to manage identity. So we talked about how LifeGraphs can incorporate really any kind of data. If I'm a doctor, my LifeGraph might include my medical degree, my license, my verifications, my CE credits. All of that trusted data is going to get packaged up and presented into things like provider directories, which then gets used for scheduling and referral systems, populating into EMR systems, all sorts of other things. If I'm a patient, my LifeGraph might include immunizations, Fitbit data, my credit score, something else. I don't really want anybody to know my credit score, so that stays private until I apply for a loan, and then I can provide a very limited consent just to execute that loan. But my immunization status needs to be reported to the state registry. So the system packages up my immunization status as a trusted data, a piece of trusted data, and adds it to the registry. Then if I move out of state, I can revoke that registry's access, or the system revokes it automatically, and automatically add that same trusted data to the registry in my new state. In both cases, the system is using trusted data and LifeGraphs and consent and governance and these trusted data networks to build a more efficient system with better automation and deeper knowledge of how all of these different processes need to work together and who needs to see what information. And it does it in a way that makes personal privacy and ownership the cornerstone of the system instead of an afterthought. The same technology provides a framework for a lot of these next generation data systems where you're dealing with massive amounts of really highly sensitive data. So HIEs are a great example of this. We talked about registries, but we start moving into things like identity networks and even some of the really cutting edge stuff around digital self and ambient twins. But the last one I want to highlight is a little more immediate. I mentioned at the beginning some of the hiccups with vaccine administration. Vaccination sites have been, we've heard reports of them running out of cards. Cards are being forged. Inventory is being wasted because people don't show up for their appointment. People are struggling to figure out how to make an appointment. These programs have a lot of moving parts. You have to coordinate between multiple different distributors and providers and insurers and public health agencies. It's really hard to make it all work seamlessly.